All right, let's get right into it. Today we're going to talk about a really serious medical condition, one you don't hear about every day, but it's so important to understand. We're talking about Priapism. So here's our game plan. We'll look at what makes this a real emergency, we'll break down the two main types, we'll get into the causes, see how doctors race against the clock to treat it, and finally, cover what the long-term outlook is really like. Okay, first things first, let's talk about the stakes here. And they are high. When it comes to priapism, there's this one phrase that doctors live and breathe by because it just perfectly sums up the urgency. Time is tissue. So what are we actually talking about? Well, the medical definition is super clear. We're not just talking about a prolonged erection. This is an erection that lasts and lasts and lasts for a really long time, and it has absolutely nothing to do with sexual stimulation. And this is the number that matters most. 4 hours. That's it. That's the magic number, the line in the sand. Once you cross that 4-hour mark, you've gone from just a physiological event to a full-blown medical emergency that needs attention like right now. And believe me, the medical literature is, well, it's blunt. It doesn't pull any punches. You see phrases like global penile fibrosis. And let's be real, that's just a fancy way of saying widespread permanent scarring. Or impaired erectile mechanisms. I mean, you know exactly what that means. The consequences are incredibly severe. We are talking about permanent damage. And here's the ultimate risk, right? The what if you don't get help? Well, the studies are pretty sobering. In almost 60% of untreated cases, 60%, the end result can be permanent erectile dysfunction. And that is exactly why that 4-hour rule is so absolute. Okay, so you might be thinking it's straightforward, but it's actually not quite that simple. Turns out, not all priapism is created equal. The very first thing a doctor has to figure out is which of the two main types they're looking at. And this distinction is absolutely critical. Think of it like a plumbing problem. On one hand, you've got ischemic, or low flow. This is like a clogged drain. Blood gets in, but it gets trapped and can't get out. This is the one that's super painful, and it's a true medical emergency. Then you have non-ischemic, or high flow. This is like a broken faucet that won't turn off. There's too much blood flowing in, usually because of an injury. It's not usually painful, and here's the key part. It's not an emergency in the same urgent way. But, and this is a huge but, look at the numbers. More than 95% of all cases, the vast majority, are that dangerous clogged drain ischemic type. And that's exactly why when someone shows up in the ER, the doctors assume the worst. It's a crisis until they can prove it's not. Right, so that leads to the big question. Why? What on earth causes this to happen in the first place? Let's dive in and unpack the different triggers. And you know what? The answer is kind of surprising. For the most common type, that dangerous ischemic one, most of the time the cause is, well, unknown. It's what doctors call idiopathic, which is just a medical term for we don't really know why this happened. However, when they can find a cause, it's very often tied to other medical issues. And we see this a lot with blood disorders, especially sickle cell disease. See, in that condition, the red blood cells can become misshapen, and they can literally cause tiny log jams in the blood vessels. And that connection isn't just a small one, it's incredibly strong. Get this, almost 90%, 89% of men with sickle cell disease are at risk for one of these episodes by the time they turn 20. I mean, that is just a staggering number. It's a really serious complication of that disease. It's not just diseases, though. Certain medications are also known triggers. We're talking about some common antidepressants, some antipsychotics, and, a little ironically, even the very medications designed to treat erectile dysfunction can cause it if they're not used the right way. And the list just keeps going. You've got other factors like recreational drug use, serious trauma to the spine, and in some pretty rare cases, even cancerous tumors that are physically blocking blood flow. So, as you can see, the list of potential causes is really all over the map. Okay, so let's set the scene. A patient walks into the ER, that 4-hour clock is ticking down. What happens next? Let's walk through the step-by-step medical game plan. And this right here, this is their roadmap. It's the actual algorithm, the flow chart that doctors use in the heat of the moment. It tells them exactly what to do, starting with figuring out, is this the clogged drain or the leaky faucet? Is it ischemic or non-ischemic? And from there, it lays out the next steps, which get more intense depending on how long it's been going on. So for that super common ischemic type, the pathway is pretty clear.
Step 1, aspiration. That's where they literally use a needle to drain the trapped blood out. If that doesn't solve it, they move to step 2. They inject a medication called phenylephrine, which helps tighten up the blood vessels. And if that still doesn't work, well, then the final step is surgery.
But here's the good news. Those first 2 steps, they work a lot of the time. Together, aspiration and that injection can fix the problem in up to 80% of cases. This is maybe the most powerful argument for not waiting around. The sooner you get to the hospital, the better the chances that these less invasive treatments will actually work. Now, if those injections just don't do the trick, it's time for surgery. The first option they'll usually try is called a winter shunt. The best way to think about it is like a surgeon is creating a tiny little pressure release valve. They use a special biopsy needle to make these small channels so that the trapped blood can finally escape and get back into the body's main circulation. And if even that's not enough to solve the problem, they have to move to a more involved procedure, the Al-Gorab shunt. Now, with this one, they're not just poking a small channel. The surgeon actually makes an incision and removes a tiny piece of tissue. What this does is create a much bigger window for the blood to get out. It's a more surefire way to relieve the pressure and make sure it doesn't just get blocked up again. All right, so the emergency is over, the immediate crisis has been handled. But what about the future? What's the long-term outlook? Let's take a look at what happens after the ER visit. And really, if you remember just one thing from this entire discussion, it should be this. The chances of maintaining normal erectile function down the road depend almost completely on one thing: how fast you get treatment. That 12 to 24-hour window is everything. After that, the risk of permanent damage just skyrockets. So we've covered what it is, the different types, the causes, the treatments, the whole shebang. Given everything we now know, what is the single most important takeaway? What's the bottom line? It's simple. If this ever happens to you, or to someone you know, an erection that lasts longer than 4 hours, do not wait, don't feel embarrassed, just go straight to the emergency room. Seriously, it is the only way to prevent permanent damage.